Next, let's consider an important secondary sign in assessing subscapularis tendon pathology, the bone-tendon interface, specifically at the insertional footprint. This region, where the tendon anchors into the humeral head via a fibrocartilaginous layer and cortical bone, often reflects the chronicity and mechanical history of the tendon. While primary signs like echotexture and tendon thickness directly show tendon integrity, subtle changes in the underlying bone can serve as indirect indicators of long-standing disease. Focus on the articular margin of the lesser tubercle. Normally it appears as a smooth, continuous cortical line. However, in pathologic states, you may observe cortical irregularity, focal erosion, or a notched appearance. These changes arise through two key mechanisms. First is mechanical overloading and impingement, as seen in subcoracoid friction during overhead or push-based movements. This repetitive stress can lead to microtrauma at the fibrocartilaginous enthesis and provoke bone remodeling or erosion. Second, and equally important, is loss of mechanical traction. A degenerative or torn tendon no longer transmits pulling forces to its bony attachment. Without this tensile stimulus, the body no longer needs to maintain mineralization at the footprint. This unloading leads to localized bone resorption or disuse-related cortical thinning. In calcific tendinitis, inflammatory osteoclastic activity may also contribute to erosion. Although these cortical changes rarely correlate directly with pain, they are highly informative ultrasound markers, helping you distinguish between acute injury and chronic tendon failure. Always correlate these signs with the patient's symptoms and age.